to Glen Ellyn Area Alumni Chapter's World AIDS Day webinar, which is entitled Community Conversations, Rethink, Rebuild, and Rise. And thank you so much for taking time out of your busy schedules. I'm grateful that this program is virtual tonight because of the inclement weather. And I hope that you find it very informative. There'll be an opportunity for you to ask questions via the chat. If you can just put your questions into the chat while the speakers are speaking, we'll make sure that those get addressed. And we have two speakers that will be presenting valuable information to us tonight. And before I introduce them,
All right.
I'd like to introduce our chapter president, Nikki Lang, and she's going to give some welcoming remarks.
Thank you. Good evening, everyone. I still see that we have a couple of people that are still joining us this evening. So I'm going to talk slow so that by the time I turn it back over to you, Charlotte, our speakers have an opportunity truly to be featured to our guests this evening. But I definitely want to say welcome and good evening. Very similar to Charlotte, I'll say that I'm also glad that this program is virtual because it allows us to have really maximum attendance in this inclement weather that we've been experiencing over the past several days. So I greet you on behalf of the Glen Ellyn Area Alumni Chapter, where over 330 members serve the community from Oak Park to Aurora. We predominantly focus on the west suburbs, and we've been doing it since 1977, so we consider ourselves to be really good at it at this point. More importantly, tonight's conversation is about World AIDS Day, and I'll just take personal privilege and say that I'm so glad that I'm a member of a sorority and an organization that continues to discuss HIV and AIDS awareness because it is still a very relevant conversation. So I want to say thank you to our committee chair and co-chair, Charlotte Lyles and Cynthia Brown Greenwood, for their leadership and always bringing us together for a meaningful conversation, as well as their committee. At this point, Charlotte, I'll turn it back over to you. I'm just as anxious to hear the speakers that you have prepared for us this evening as the rest of our guests. Again, welcome and enjoy the presentation.
Thank you very much. Appreciate your opening remarks. And just one other thing, I made an observation today. I remember when World AIDS Day first started, we were wearing red ribbons. Everybody made a point to wear red. You turned on the TV, you saw news anchors all dressed in red. And I looked at a couple of different broadcasts today, and I think I saw one male anchor with a red tie on and one female anchor on a different network with a red dress on. And it seems that we've let World AIDS Day fall a little bit off of the radar screen, but as Nikki was saying, it's a very relevant topic. I think we've gotten into a little bit of a comfort zone because there have been treatment advances that have allowed people to live with HIV without it going into full-blown AIDS. But as our speakers will tell you, there are many reasons for us to remain vigilant. And without further ado, I'm going to introduce our first speaker, who is Dr. Yvonne Collins, and she is a gynecologic oncologist with Cook County Health. She received her bachelor's degree from Xavier University in New Orleans with high honors, magna cum laude, and she went to medical school at University of Florida in Gainesville. Like I said, she's currently with the obstetrics and gynecology department with Cook County Health, and she is also on the leadership team of the National Medical Association. Currently, she's on the board of trustees and she is the chair for Region 4. She's also a member of the Society of Gynecologic Oncologists. She's a member of the American College of Obstetrics and Gynecology, the American Medical Association, National Medical Association, Illinois Medical Association, Chicago Medical Association, and Cook County Physicians Association. So without further ado, I'm going to turn the floor over to Dr. Collins and have her share some information with us this evening. Thank you, Dr. Collins.
Good evening. Thank you so much again for the invitation. I am really excited to be with you all this evening. I'm going to share my screen. While I am talking and sharing my screen, this is a reminder. I think the topic is one that one second, that um, really highlights the benefits of research and all of the changes that we've made related to research. One second, I no longer have a share bar, so I'm trying to see where it went.
It's sharing. I see it.
All right, there we go. So we're going to really keep it high level this evening. We're going to talk about what is HIV, how we diagnose it, how we treat it, but more importantly, how we prevent it. And if you don't get anything else from this evening, I want everybody to understand that we are all at risk and there's something that we can do about it. So, just as a reminder, HIV stands for the human immunodeficiency virus. It's a virus that attacks the human body's immune system. That's our white cells that helps us fight infection. And when it attacks the immune system, it weakens the immune system and it makes it much easier for you to get sick. I'll highlight at the very beginning also AIDS because sometimes people still sort of use them synonymously and they are very different. So, the acquired immunodeficiency syndrome, which is AIDS, is caused by the HIV virus. It occurs most commonly when HIV is untreated, and it too weakens the immune system. And when we talk about counts and diagnoses, this is one scenario where if your CD4 count, which is some of those immune cells, is less than 200, or you have a condition, which we'll talk about a little later, that helps us with the diagnosis of AIDS. So tonight we're going to start really high globally and then bring it on down to Chicago. When we look globally at the epidemic of HIV, globally there are 39.9 million people that live with HIV currently. When we look at that breakdown, the vast majority of those are adults, but we still have 1.4 million children worldwide that are afflicted. To keep it in context, when we look at people that actually die from HIV related causes, about 630,000 deaths each year globally still related to HIV. Lots of work that we have to do. When we look at the United States, slightly older data, but not much has changed. 50% of all of the active HIV infection in terms of diagnoses are in the South. You can see 52%. You can see where we stand here in the Midwest at 13%, just as the Northeast. And then coming in second is the West Coast. If we look at the United States by age, we can see that the vast majority of people, more than 50%, are people aged 13 to 34. So when we think about our early teenagers, we're still seeing them being afflicted with HIV. What I also want to highlight on this slide, we have 9% of the population that's greater than 55. Very seldom we don't talk about 55 and older. We especially don't talk about 65 and older, but we can still see that 2% of that population still acquires the HIV infection. This is a very busy slide, and I do apologize for that, but really wanted to highlight some important factors when we talk about the older population. When we look at HIV testing, despite the highest percentage of late HIV being in only 19% of the older individuals, we can see that 34% of those are diagnosed late in disease, late in age. But also, more importantly, is who's actually receiving care for that diagnosis. And we can see that the population 65 and above is the lowest percentage of those that actually receive care for their HIV. And we're going to talk a little bit about that more when we talk about some of the race and ethnicity data. We know that there are unique challenges that our older population faces, really related to social isolation, related to loneliness. And for all populations, there is, even in 2025, a stigma that's associated with HIV. If we look at it by race, we see that the African American population and the Hispanic population, if you put those two populations together, that's almost 70% of those diagnosed with HIV in the United States. When we look at it, we know that there are racial and ethnic differences that continue to persist over many years. Some of that is the stigma, but we know a lot of it is due to discrimination. It's due to homophobia. It's due to poverty. It's due to access to care. So when we talk about really access to care, we have to continue to focus on access to all care, including diagnosis and treatment of HIV, if we really want to get past the racial and ethnic differences with this disease. When we look at it by transmission rates, again, the vast majority, almost 70%, are male to male sexual contact. And that is gay men, bisexual men, but also other men who may not be denoted as such, but still have male to male sexual contact. I do also want to highlight for the heterosexual population, there's still 22% of transmission via heterosexual contact from either men who have sex with men or women who have IV drug use. So there's still a population within the heterosexual context that are still at risk. When we look at our trends for Illinois, we haven't really done a great job. If you look at the last 15 years, we can see that the prevalence has slightly increased in terms of AIDS. We can see that the incidence has only decreased slightly. When we look at late diagnosis, we're doing a little bit later, better with late diagnosis. But if we look at mortality, which is this red line, that is death from HIV, we can see that we've really plateaued. We haven't made significant strides from 2016 to 2020. And sort of stopped at 2020 due to the pandemic. But if we look at these numbers even now, we have not still made significant progress here in the state of Illinois. I thought I'd then bring it on to Chicago. When we look at Chicago in terms of our city demographics, again, over 50% of our city demographics related to race and ethnicities are Black and Latin folks. You can look on the map here just for context. If you are light blue, you're low rates. If you are red, those are high rates, and gray are even higher economic hardship. So really, if you look at those areas that are gray and red, we know that those are primarily areas where there are Black and brown folks. If you look at the middle of the screen, that breaks down our great 77 neighborhoods of Chicago. And you can see when we look at the highest impact community areas, it's North Lawndale, it's Washington Park, it's South Shore, it's West Inglewood, in addition to Great Grand Crossing. And when we look at those, more than 29.1 new cases per 100,000 folks. So if you look at where the communities are that need access and need testing and need intervention, you can choose any one of those in red as a
Want to
impact
just be
area.
on, just like, but they were
When we
empowered
look,
at the same time.
can we mute? Thank you. When we look at transmission, that is how HIV is spread. It's primarily via bodily fluids. So that's blood, that's breast milk, that's semen, that's vaginal fluid, rectal fluid, and also transmission from mother to baby. HIV is not transmitted solely by touching, not solely by hugging. It's not transmitted through the air. It's not transmitted in our food. We know that it has to be a transmission of bodily fluids in order for this virus to spread. This slide is really small, but I wanted to highlight really the progress that has been made with HIV and AIDS. So if we remember in 1981, that's where the CDC first began to make the diagnosis of AIDS. And if we look over time, this graphic really highlights impacts that we've made related to drug therapy, impacts that we've made related to legislation, impacts that we've made related to have we gone from folks having to take 5 or 6 pills to now being able to take one pill or no pills and be able to take an injection. And now, even to the point where there are mechanisms for us to be able to prevent HIV and ultimately AIDS. When we look at symptoms, early on in those first few weeks, you could have absolutely no symptoms. Early on, very commonly, you have what feels like flu symptoms. So it's going around now, and many of us have seen it, but fever, headache, rash, sore throats. If those are symptoms that you have that persist, that is beyond weeks to months, it probably warrants some additional evaluation. Later on in the stages of HIV, you have swollen lymph nodes, you have unexplained weight loss, you have unexplained fever, persistent diarrhea, and cough when we look at those, and it depends on stage. When we look at HIV without treatment, there's a whole array of what we call AIDS defining conditions. So HIV hasn't been treated. You don't know that you have HIV, but all of a sudden you appear with one of these diseases on the screen. That's a condition that now says you have had HIV and have gone untreated. And now you have what is we call a defining condition related to AIDS. So there are viruses that can infect your eyes that cause loss of vision. You can get high intensity pneumonias. You can get intestinal diseases. HIV can get into the brain where it causes what could potentially look like a dementia or delirium. That's an encephalopathy. You have tuberculosis, unexplained. And I always like to highlight can have invasive cervical cancer. So all women that present to the clinic with a newly diagnosed invasive cervical cancer should always have HIV testing to make sure that that's not a disease that was one of the etiologic agents for HIV spread. When we talk about risk factors, anyone that has unprotected sex is at risk unless you absolutely know your status and the status of your partner. I talk to teenagers all the time. They think they're invincible, but I always like the screen of think about it. You have sex with one person, but in actuality, you're having sex with everybody they ever had sex with, and that puts you at significant risk. Sharing needles, especially with infected persons, puts you at risk. We have lots of needle sharing programs here in Chicago for those folks that may be drug users, so you don't have to share your needles. Transmission from mother to baby. With the advent of HIV therapy, we've almost eliminated the transmission from mom to baby. That's if you've been tested, we know you have HIV and you're on medications. And then infection from blood products. Again, almost nil, but we want to make sure that we always bring that as a point. Not only HIV, but other infections can be transmitted via blood products. So diagnosis, there are FDA approved diagnoses for blood, for saliva, for urine that you can use for diagnosis. If you've never been tested, I recommend that everybody get tested. I also recommend that everybody's tested at least yearly. What we call point of care testing, that's usually what happens in the community. You are give a sample on site, takes about 15-20 minutes. You get that diagnosis that day. But you also have to make sure, even if we get a positive diagnosis at that point, you have to have confirmatory tests to make sure that it's not a false positive. But you can have a test in the doctor's office, you can have a test in the community, you can have a test even at home. There are an array of ways for you to get tested, but the most important part is that you are tested. When we talk about treatment, again, this looks at the milestones of timeline related to treatments for HIV. Again, 1981, that was when the CDC began to publish the first official report of HIV-related disease. We had our first approved therapy, which was AZT in 1987. If any of you saw, I'm going to show my age now. If any of you saw the movie Philadelphia, when the medications were taken, the patient got really, really sick with AZT. We then developed a new standard of therapy for HIV, which was heart therapy 10 years later. Then, if you think about from 1997 to 2012, miraculous advances in terms of how you do treatment. 2012, we had our first treatment, which we're going to talk about a little bit later, that allows you to take medications before sexual intercourse to decrease your risk. 2014 was really the announcement of a 30% decline from 2002 to 2011 in HIV diagnoses, which was phenomenal. And then our first long-acting injection for HIV in 2021. So again, each of these steps along the course of treatment was made because people decided that they wanted to volunteer for clinical trials. These are the numbers of drugs that are estimated for HIV that will go to market between 2024 and 2034. So if you look at it, this is the sort of the amount of money that we spent in 2024. Last year we spent about 34, that is B with a billion, and it's estimated to go in the next 10 years up to 53 billion in terms of what we spend to treat. I won't get into the names of the medications, but know that each of those colors on that graphic highlights a different kind of medication. So there are many different types of medication that we use for HIV, but the treatment is all the same. Can you eliminate the virus so that those who are HIV are undetectable, and that way they are no longer able to transmit HIV? This is the prevention pipeline. Everyone always asks, what can I do? What can I do? What can I do? So if we look at the far left, these are things that are in development. So there are implants that are in development. There are vaccines to prevent the virus that are in development. There are patches and films and vaginal gels that are in development. They are even looking at ways that you can douche differently as a prevention method. Those are all in development. Let's go over to the right side of the screen, and these are advances that we have that are available right here and now. As simple as a condom, that is whether it's a male condom or a female condom. There's a lot of literature that points to increased transmission with males that are uncircumcised, so voluntary circumcision. There are syringe exchange programs if you are an IV drug user, but there are medicated vaginal rings that can prevent HIV. There are two now injectables on the market. So when we think about prophylaxis, that's prevention. So there is prevention that you can take even before you're exposed. That's called PrEP, pre-exposure prophylaxis. Those are injectables or a pill. Then there is what we call PEP, post-exposure prophylaxis. So you had intercourse, you didn't know the status, you all of a sudden found out the status of that person, or you don't know their status and you're controlled. That's when we begin to talk about PEP. That's after you've already been exposed. But the importance of this slide is that even if you don't know your status and you don't know the status of anyone you're going to have sexual intercourse with, there are alternatives and options that you can take to prevent the transmission of disease. And I think that's very important for you to know. Testing is key, diagnosis is key, but prevention is very important when no one knows their status. PrEP, I wanted to talk about in the light of, again, if we talk about Black women unfortunately represented 40% of the new HIV diagnoses, but again, only 14% of the population were actually advised that PrEP was an option. When we look again at Black women and new cases of HIV, 50% of those new infections in women are Black women. Again, when we look at the states that are at risk, we know the rate of Black women living with HIV in the South is 14 times higher than that of white women. So if there's anyone on the phone from the South, if you have family in the South, this is a population where diagnosis and testing and PrEP is even more important because of the astounding numbers, not only of the South of HIV, but the numbers of Black women that are impacted. And those are heterosexual Black women that are impacted each and every day. When we talk about treatment, so the goal of treatment is to take a medication that stops the virus from multiplying. You stop the virus from multiplying, all of your infection counts go down, your infection fighting counts go up, and you can no longer spread the virus. That's what we want. We want the virus to be undetectable in you, and then from there, it's untransmissible to anyone that you have sexual encounter with. And again, options are pills or shots, but the goal is making that the antiretrovirals, that's what the name of the medication is. And the goal is to make the virus undetectable. This is another schema that looks at just the importance of research. I won't go through it. This one highlights the different kinds of drugs. And why do I put this up? Because if you remember, I mentioned earlier that when we look at HIV, unfortunately, we know that there are disparities related to race and ethnicity. We know when HIV came on the front in 1981, it was primarily a disease of white men. We know that that's changed over time, but if you look at the amount of research that has been done in this disease, it's amazing. Almost every 2 to 3 years, in some cases, there are new drugs that come to market, new strategies in terms of prevention. And why do I say it's important? Because if we look at diseases, say sickle cell, that impacts primarily Black communities, we have not had a new drug on the market until recently in the last 20 years from sickle cell. And the numbers in terms of those that are impacted and affected are very similar in terms of what we see in the HIV population. This is why clinical trials matter. When we look at clinical trials specifically related to HIV, you can see the vast majority, 78%, were men, despite what I just told you about the number of women, especially Black women, that were impacted. And the vast majority of them were white. And so I encourage this conversation about clinical trials is really important. There's a lot of conversation that I don't want to be a guinea pig, the Tuskegee experiment, they stole Henrietta Lacks cells. All of those things are true, but there's been so much progress in terms of education and training before research can be done, that those things are not as imperative as they were before. And I just want to highlight for the audience that if you are not a part of the research, you'll never know the impact that these particular drugs will have on our community. We are seeing it now. There are many drugs for high blood pressure that are given each and every day, and we wonder why blood pressure is not controlled because they've never been studied in Black people. And so we want to make sure that our community understands the importance of clinical research and clinical trials really for all diseases. So as I conclude, HIV is not curable, but it is controllable. We've seen that over the last 20 years. I encourage each of you, even if you think that you're in a monogamous relationship, to get tested regularly. Know your risk, because if you know your risk and your partner knows their risk, if either one of you are at risk, there are prevention methods. And get involved in research, get involved with having the conversation. I am part of the Delta Research and Educational Foundation All of Us Research Program, and I'm going to show this video. But what the program is doing is trying to build a database of 1 million participants. We know that we can't do research with one small population like the slides that I showed you. Every clinical trial cannot be white men. We need Black women, we need old, we need young, we need bisexual, we need transgender, we need those that are differently abled. And with that, we'll really be able to understand the impact that medications and treatments will have on diseases. So I'm going to play this video and then we'll take questions if there are any.
Well, I think that what's unique and important about the All of Us research program is that, there are treatments and medications that don't work for everyone. And this program is really trying to find out why. They're looking into lifestyle, your environment, your genetics to get that answer. And I think that that's important. Personally, I wanted to become a participant in this program and be involved because as a Black person living in America, I know that we've been left out of biomedical research largely in the past. And this program is also looking to change that, and they're looking at more diverse populations. I would say to anyone who has reservations about joining that you could possibly be a part of medical breakthroughs in the future. Why would you not want to be a part of that? I'm Chantel, and I joined for All of Us.
So if you are interested in joining All of Us, we'll drop the link in the chat, but you can go to joinallofus.org/DREF, and we'll be happy to have a conversation with you. Again, thank you very much for the conversation this evening. I will stop sharing, and I'll turn it back over to Charlotte.
Yeah, thank you very much, Dr. Collins. We appreciate all the information you shared with us. And like I said earlier, if anybody has any questions, if you can please put them in the chat, we can go ahead and get them to Dr. Collins. I do have one question. I thought it was really interesting that so many of the infections, about over half of them, are located in the southern region. And we typically think of those southern states as being red states. Do you think that there's a correlation between the fact that a lot of those red states did not opt into the exchanges to provide health care under Obamacare and the fact that we're seeing such a disparity with the infection rates in the southern region, or are there some other confounding factors?
Yeah, I think there are definitely confounders, but when we look at the Affordable Care Act and the expansion of Medicaid, we know that that becomes an access issue. So when folks don't have access to being diagnosed, they don't have access to treatment, we're going to see that. They don't have access to prevention, we're going to see that. And that's definitely some of the reason why. What we also have seen is that if you look at that southern region, we have a lot of um, populations that have been that have had bias against them in terms of the healthcare system. So they are less likely to go into the institution. They haven't found providers that can relate to them, that don't stigmatize them. So I think there's a combination of all of those things that come into a play when we talk about that population.
All of us, even up here, that we've got to be our own advocates for ourselves. And if you don't like what your physician is telling you, get another opinion, a second opinion,
Absolutely.
because the life you save could be your own. One other question. Can you talk a little bit more about the link between HIV? You mentioned cervical cancer as being a predictor of HIV positive status. Can you talk a little bit more about that, please?
Yep, absolutely. There are probably three cancers that are associated with HIV. So we have lymphomas, which are cancers of the lymph nodes. We have Kaposi sarcoma, which is more of a sort of a skin type of cancer, and then an invasive cervical cancer. What we know also with HIV is that, like I talked about early on, it destroys your immune system. So you really become susceptible not only to viruses that can potentially cause cancers, but you also become increased in terms of susceptibility to other sexually transmitted infections also.
All right. Thank you very much. You shared quite a bit of information with us, and we're truly grateful for your time and also for putting a spotlight on the All of Us program with DREF. And as a token of our appreciation, my committee, International Awareness and Involvement, will be making a donation to American Cancer Society on your behalf.
Thank you so much. That's
Thank you.
fantastic.
Hey, thank you
Charlotte,
for
there are
being
a few
with
more
us.
questions.
Oh, great.
Dr.
Yeah.
Collins, what barriers are preventing women, especially Black and Brown women, from receiving timely screenings?
Yeah. So are we talking about screening in general, or are we talking about testing for HIV? I'll sort of talk about both of them. So when we talk about HIV, I think the stigma it's stigma that comes along with you not only being HIV positive. Also, we make perceptions about people. She doesn't look like she would be someone with HIV. She's happily married, so she doesn't need to be tested for HIV. Those are things that I think impair those folks that should be tested from not being tested because we place those stigmas or perceptions of what we have on people. The other part of screening very commonly is access. Can you afford it? Does your insurance cover it? Although most do. Is there pain associated with it? I hear it all the time in terms of pap smears and mammograms. Do you have the time? Can you take off work? That's why some of the screening that you can do at home becomes really important. I would probably say those are some of the barriers, but I'd probably say the barrier that I hear about most is communication. The provider doesn't recommend it. And so in a lot of cases, I may not know that I need it. And so that's why some of the advocacy for yourself and understand what you should be screened for, how often you should have your thyroid checked, how often you should have those screening tests become really important, because then you can walk into the doctor's office and you can say, I'm 55, I haven't had my colonoscopy, I'd like to have that scheduled.
Is there another question, Sabrina?
How can communities rethink their approach to HIV prevention and care in today's climate?
Absolutely. We should look at HIV just like we look at every other disease. If I told you today that there was going to be a vaccine that would prevent breast cancer, there would be lines and lines and lines of people wrapped around the block. When we talk about HIV, no one wraps around the block very commonly. Nobody wants to talk about it. It's really, really hush hush. And until we bring it to the forefront and begin to talk about HIV the same way we talk about heart disease or breast cancer, we're really going to be in the predicament that we're in, and people are going to be shy about it because they're going to think about, what are people going to think of me, and what are they going to think I am if I ask for an HIV test or I tell them I'm HIV positive. We have to look at it as just another chronic disease, and if we don't test people, we can't treat people.
Thank you. Any additional
Absolutely.
questions, Sabrina?
What symptoms or risk factors should providers and patients pay close attention to when considering the overlap between HIV and gynecological cancers?
Absolutely. So, unexplained symptomology. So, weight loss, especially fever, swollen glands. So, we very commonly see swollen glands with advanced cervical cancers. So, those are things that sort of overlap. But again, the vagueness that HIV has at the very beginning can mimic lots of different kinds of winter illnesses. So, I'll say if those things are persistent, be vigilant about being evaluated.
Thank you.
Okay, thank you.
Thank you.
All right. Well, thank you once again, Dr. Collins. We appreciate all the information and for answering those questions. And like I said earlier, if you have any questions, please continue to put those in the chat. Now I'm going to introduce our second speaker for the evening. His name is Timothy. Let me get my papers together here. Timothy Jackson, and he currently serves as the Senior Director of Policy and Advocacy for the AIDS Foundation of Chicago. And in that role, he leads, guides, and supports the development and implementation of various activities for advocacy, also on the federal level, the state level, as well as the municipal level. And he's also involved in advocacy when it comes to different policies that impact patients with HIV, AIDS, and homelessness. And oftentimes, unfortunately, homelessness is related to people with HIV, AIDS. As a Black gay man living with HIV, Timothy's career is deeply rooted in advocating on behalf of people living with and vulnerable to HIV infection. He wants to amplify their voices and address the impact that HIV has not only on those individuals, but also their communities. And his heart for advocacy is born out of a personal promise that he made to an aunt of his who died from HIV, from AIDS related complications. And he promised her that he would spend the rest of his life advocating on behalf of people with HIV and AIDS. And he's a self described lobbyist, policy wonk, foodie, a creative, a storyteller, a man of faith, but most of all, a fierce advocate. And without further ado, I'll introduce Timothy Jackson. Thank you so much, and you can please come off of mute. Thank you.
Thank you so much, Charlotte, for that gracious introduction, and thank you all so much for you all joining us for this commemoration of World AIDS Day. As Charlotte mentioned, my name is Timothy Jackson. So proud to be with you all this evening. This obviously World AIDS Day, as a person living with HIV for over 16 years, is deeply personal. This is probably, I think, my fourth interview / presentation today. So I'm a bit kind of tired, but we persist. But as Charlotte mentioned, at the very heart of the work that I do is a promise that I made to my late aunt that I would spend the rest of my life advocating on behalf of people living with and vulnerable to HIV. And that is the reason why I do the work that I do. And so one of the things that I get to do, and I want to be very clear when I say that I get to do this. This is a privilege of mine to be able to affect policy change that impacts people living with and vulnerable to HIV, on the federal level, on the state level, and also on the municipal level. And so, because what we have seen in DC, which is what I'm going to spend primarily most of my time talking about, everything that we're seeing out of DC is impacting people living with and vulnerable to HIV here in Illinois, and the steps that we're going to need to put in place on the state and local level to make sure that our communities are protected. And so one of the things, before I get started, I do want to thank Dr. Collins for their presentation and going over that. And I do want to mention that before I get started. But I want to put in the chat and share this document, something that obviously this year has been the year from hell. With a lot of chaos that has ensued out of Washington, D.C. and our federal government related to a variety of issues. But obviously today I'm going to talk about the impact of those policies on people living with the vulnerable to HIV. And so as I was pulling all of this together, just kind of really thinking about it, the terminology that came to my mind was everything all at once. And what we have seen, Dr. Collins shared kind of the 40-year plus history or so of the HIV epidemic, right? And talked about how it kind of started and how we got to ACT and we started getting better treatment, and you could see kind of the flow of that. And so it's taken 40 plus years to create this infrastructure that takes care of people living with HIV, vulnerable to HIV, that does all of the awareness, the education, the prevention around HIV, right? And in less than a year, this administration in the White House has essentially gone about undoing 40 plus years of that work. And so when I say everything all at once, it is, if it was just one thing that they focused on, that would be enough. But it is literally everything all at once, from housing to mental health care to funding to prevention to treatment to DEI, to all of these things are really compounded on itself and have made it such a very difficult time to do this work. So what I mean when I say everything all at once is in this document that I hope is being shared out. I have listed just one or two major events that have happened every month since President Trump's second inauguration on January 20th. Just one or two that are related to HIV. And this is really just going to provide a picture, paint a picture of what we're dealing with. And so we start literally on the first day. He issues an executive order titled Ending Illegal Discrimination and Restoring Merit-Based Opportunity. That's also known as the DEI Executive Order. This is going after Black and brown folks, right? This is going after anybody that is not a straight white man. And you may say, well, why is this important to HIV? It's because what we have seen, especially from the Biden administration to the Trump administration, the Biden administration had made serious strides in addressing health disparities, specifically racial health disparities. And so not for just HIV, but for maternal health, for a host of different things. And so this executive order basically rips all of that up. All of that work, gone. And so now you have an administration that doesn't address any of these disparities. Dr. Collins did a phenomenal job of outlining the disparities that we see, right? And Dr. Collins laid out those numbers. The Trump administration said, the hell with that, with this executive order. On the first day, still, they issued an executive order entitled Defending Women from Gender Ideology Extremism and Restoring Biological Truth to the Federal Government. This was the quote-unquote gender ideology executive order that was going directly after LGBTQ folks and specifically transgender and gender expansive communities. All these communities are disproportionately impacted by HIV. So, because you have rolled back rights for these specific communities, they now have a harder time accessing services, accessing anything. And again, this is an intentional effort, right? And part of what we have seen at the end of January, and I did this story for Reuters, that the CDC actually scrubbed their websites of a lot of mention about HIV, about gender ideology, about health disparities. They literally got rid of it off the websites. And so to tell you, obviously, I don't have to explain how important this is, thank you, for this, is we're talking about health disparities, right? Well, if you take it off the website and you use the CDC has always been the CDC. This is where you go for actual information, right? Well, if you take that off of the CDC's website, where do you get that information now, right? So we fast forward to February. And unfortunately, Robert F. Kennedy Jr. is sworn in as Secretary of the Department of Health and Human Services that has oversight of literally this country's health infrastructure. So that's the CDC, that's the NIH, the National Institutes for Health. So thinking about research funding and research has oversight of that. Centers for Medicare and Medicaid Services. HRSA, which is the second one on there, that has oversight of everything HIV related. If you've ever gone to an FQHC, a federally qualified health center, HRSA is the federal agency that represents that. Substance Abuse and Mental Health Services Administration. Obviously, its name tells you what it does. And so he's now secretary of this massive department. If I'm not mistaken, at last count, only the Department of Defense is larger than HHS. in the federal government. And so that just tells you literally have someone who does not believe in vaccines, has said egregious things about HIV and how it's transmitted, but yet you have him as the Secretary of the Department of Health and Human Services. You also have him who has he's wanted to go in. He had already said he wanted to go in and change HHS and create the Make America Healthy Again administration. Just creating havoc and chaos for the hell of it. In March, we see the National Institutes of Health terminating at least 145 grants related to researching advancements in HIV care. Dr. Collins mentioned the importance of clinical trials. The Trump administration, through the NIH and Robert F. Kennedy Jr., terminating at least 145 grants, totaling nearly $450 million in federal funds. So all those new, that slide that Dr. Collins showed about all of the things that are coming down the pike, yeah, maybe not so much, because they have terminated them. In April, as I mentioned, the Trump administration began sweeping cuts to the Department of Health and Human Services, which resulted in the dismantling of a range of divisions and agencies within the HHS. I was in Washington, D.C., actually for AIDS Watch, which is our federal HIV advocacy day, where there were literally HHS staff standing outside of the Hubert Humphrey building in D.C., wondering whether or not they had been laid off, wrapped around the building. Again, just firing people with little regard. And obviously, you made tremendous cuts to the CDC, the NIH, HRSA, fired so many people that do the work of trying to end the HIV epidemic. In May, President Trump releases his proposed federal budget that includes a $1.5 billion cut in domestic HIV programs compared to fiscal year 2025. $1.5 billion. This is so bad that budget includes getting rid of the HOPWA program. We talked about the intersection of HIV and homelessness. Charlotte mentioned that in my bio. Well, HOPWA is the federal program that takes care of people living with HIV. Stands for the Housing Opportunities for People with AIDS. President Trump's proposed budget would get rid of that program. It would get rid of the Minority AIDS Initiative that was created by Representative Maxine Waters of California. That would get rid of Ryan White's Part F. That would get rid of even the president's own Ending the HIV Epidemic initiative. President Trump, in his first term in 2019, created the Ending the HIV Epidemic, which was an equity-based way of addressing HIV that basically looked at the map and said, where are the numbers, the larger numbers for HIV incidents? And so those places, whether they be municipalities, like here in Illinois, it only went to Cook County. But like down south where I'm from, it went to entire states like Mississippi and Alabama. Okay? And so essentially what we have seen since they implemented that program, it was working. It was working. I mean, who knew that if you put increased investments in something, that it would work? I mean, who knew that? But even his own program, he included in his proposed budget to end it. That's just how crazy this is. June 2025. HHS Secretary Robert F. Kennedy fires all 17 members of the CDC's Advisory Committee on Immunization Practices. And we have kind of seen what's happened after this. Again, I told you he was a vaccine denier, all of those things. Obviously, and I'll mention this in just a moment, this has impacts on other things. Because again, he provides guidance and leads all of these agencies. He is the person at the top of all of these agencies with oversight. Scrolling on down, we see the Food and Drug Administration approved Yes2Go, which is that's the brand name, but the drug is called lenacapavir. It's the first twice yearly injectable pre-exposure prophylaxis for HIV prevention. What that means, it's an injectable that prevents HIV that you get a shot twice a year. It's huge news, right? That's awesome. But the problem that we're going to run into this is the same problem that we've been running into PrEP uptake on a lot of things is the cost of it. And why that's so important is because yes, on one hand, you have this great news. This is great, right? But how can people afford it? Especially when you're trying to take their health care away from them, which I'll mention in just a moment. June was a crazy month. We also had the Supreme Court ruled in Kennedy versus Braidwood Management. The court ruled that the structure of the Preventative Services Task Force is constitutional. If you're not familiar with this, and I apologize for getting too policy wonkish, the USPSTF, this task force, basically looks at all preventative services that you get in insurance, right? And they'll determine recommendations. They give out grades, essentially. And the way federal law is, it says that if the USPSTF gives a recommendation of either an A or B, that means insurers have to cover it without cost sharing, meaning no copay. So what is covered under that? Oh, your vaccinations, your mammograms, colon screenings, and PrEP. All of these things are covered. So obviously that was great that they upheld that, because we were really kind of nervous going into this, to be honest with you. But the problem is they also ruled that Secretary Kennedy has the power to add and remove members at will, which he's already done. Remember, I just told you he did that with the vaccination panel. And essentially what we're looking at right now is he could essentially, because of what the Supreme Court is allowing him to do, he could get rid of the entire panel, put new people on there that will do his bidding, but not in the interest of safety or science. Okay? And then finally in June, we saw the Trump administration issues a recession package that included a proposed $400 million cut to PEPFAR. PEPFAR is the United States fund that provides HIV/AIDS prevention and treatment relief around the world. It was a program that was created by former President George W. Bush. It is wildly successful, saved over 26 million lives, bipartisan in nature, has always been bipartisan in nature. And essentially, it took, believe it or not, some Republican senators standing up to the president that basically told him, no, we're not going to cut PEPFAR. This is just how crazy, and we're only mid-year. Moving down to July, we have this chaos that is called H.R. 1, which is the One Big Beautiful Bill Act that was signed into law on Independence Day. The Congressional Budget Office estimated that this bill will result in 11.8 million Americans losing their health coverage under Medicaid over the next decade. Why is that important for people living with and vulnerable to HIV? Illinoisans living with HIV, 42% of them rely on Medicaid for their health care. 42%. It's even higher than the national average. The national average is about 40 to 41. In Illinois, it's even higher. So you take away Medicaid, how are you going to take care of these people, right? And keep in mind, if you have Medicaid, Medicaid is for low-income people, right? Then, because that wasn't enough, President Trump issues an executive order titled Ending Crime and Disorder on America's Streets that prioritizes federal funding for jurisdictions that take punitive and unethical actions, such as punishing people for sleeping on the street and forcing individuals facing mental health or substance use challenges into treatment facilities against their will. Essentially, this is criminalizing people who are unhoused or homeless and confining people who are dealing with mental health or substance use challenges, and like you're civilly like confining them. That is absurd. Full stop. But you may say, well, why are they allowed to do that? Because you don't know if you remember this, in June of 2024, the Supreme Court in Grants Pass versus Johnson, I believe it is, issued an order that allows municipalities to do the same thing. That instead of providing housing or trying to get someone into treatment, you're just going to throw them in jail. You're going to fine them. That's absurd. And again, as we talk about the nexus between people who are unhoused or are dealing with housing instability and people who are living with the vulnerable to HIV, they're tied together, right? And so that's kind of where we are. I'm going to be honest with you. All of this is trash. I'm going to be completely honest with you. But I think this one probably hurt me more than any of the other ones. I literally was walking into see The Lion King this summer. Was it Lion King? No, Color Purple. And I just happened to get this alert on my phone. And I don't know why I looked like, I wish I had, because it almost ruined my night. Like reading this executive order. So we get to August. I told you he had already tried to take away all of that money from PEPFAR. He wanted to basically get rid of it. Well, there's this little thing, where you can withhold millions. So he was like, he didn't like that the Senate Republicans rebuked him. So he still is going to release only about half of the $6 billion Congress had already appropriated for the program. And again, I told you what PEPFAR does. Then he also refused to disperse money that had already been appropriated by Congress for the Ryan White HIV/AIDS program Part F grantees. And so, and Ryan White Part F encompasses the AIDS education and training centers. We have something here in the Midwest called the Midwest AIDS and Training Education and Training Center, MATEC. They are essentially, they train providers on how to provide HIV care, HIV prevention, all of the things. Great organization. Again, withholding funding for them. Then we get to September, and we find out on the Sunday before Labor Day, the House Appropriations Committee proposes significant cuts to HIV funding. Now, I mentioned the president's proposed budget back in May. The House Appropriations Committee, i.e. Republicans, was even worse. Because whereas the president only wanted to get rid of Ryan White Part F, the House Appropriations Committee wants to get rid of Ryan White's Parts C, D, and F. Again, these parts take care of people living with a vulnerable HIV. They provide funding to clinics in order to be able to do testing and the treatment and prevention and education and provide it for women and children. Dr. Collins mentioned that here in Illinois and across the country, what we now call vertical transmission or mother to child transmission is essentially non-existent. We just don't see it anymore. And why we don't see it as often anymore? It's because we put in the work and the investments to make sure that no longer occurs, right? Well, House Republicans want to say the hell with that, okay? Just being honest. Also, it would cut the Ryan White program by $525 million. Then you can keep going. You can go down. Then we have Robert F. Kennedy Jr. again, my favorite cabinet secretary, fires CDC Director Susan Monterez because she refused to approve vaccine recommendations without scientific review and refused to dismiss career scientists without cause. Keep in mind, she had only been in that seat, I think, maybe 2.5 months. She had just been approved by the Senate, I want to say in mid-July. Then the CDC issues clinical guidance for use of injectable lenacapavir as PrEP. That was that injectable that I talked about earlier, right? That the FDA came out and said this is the newest drug. Well, the clinical guidance is something that the CDC usually does. It basically tells providers, medical providers, how to use it, essentially. The problem with this is the guidance does not include reference to transgender people, a group intentionally included in the clinical trials and at increased risk of HIV. Again, just another dig at transgender and gender expansive folks. We get to October 2025, and we see the federal government shut down for the first time in 7 years, the longest in history at 43 days. And really at the heart of it is because Congress had not passed its budget. And the extension of the Affordable Care Act premium tax credits that allow people to afford their health care through the Affordable Care Act, also known as Obamacare. Then we get over to November 2025. This is cruel. This is what this is. The administration issued a significant policy change to what we call the continuum of care, which funds homeless services. It shifts more than half of the program's funding away from permanent housing to more transitional housing. For about the past decade to 12 years or so, there has been an emphasis on permanent supportive housing, meaning it's not just enough to get someone into a shelter. We want to get them into a home permanently. Like, where we're not worried about them a month from now being back out on the street, right? They have basically put that program on its axis and turned it upside down. And obviously that is a tremendous problem. Because you're already criminalizing people who are sleeping outside. Then you want to civilly confine people who are dealing with mental health, issues or substance use. Now you're basically telling them that you can only do transitional housing. Make it make sense. Make it make sense. And then today, for the first time since its inception in 1988, the White House refused to acknowledge World AIDS Day, citing that, quote unquote, an awareness day is not a strategy. And so when I say everything all at once, that's what I mean. And these are just some of the high level. Y'all, it gets even worse, to be honest with you. I did not want to further depress you, especially this late in the evening. But it is difficult to continue to do this work when literally every day something else comes up. And you're like having to hold this while having to hold this and get your foot on something else. And you're trying to keep things going in spite of, right? And what I will close with before we open it up for questions is all of these changes are going to amount to one thing, to two things, really. We are going to undo all of the progress that we have made in the 40 plus years of the epidemic. And people will die. And I'm going to be completely honest with you, people that look like us. I am being honest as I can. Because that's why it's so important for me to do these types of talks. That I am being honest with you all with what's at stake and what we need to do moving forward, that we have to continue having these conversations. Yes, it's nice to do it on World AIDS Day, but what are we doing on December 2nd? Right? What are we doing on March the 23rd, random day? You know, what are we doing every day in our communities? And again, you don't have to do something big, but what are we doing every day to let people know about PrEP, to let people know about U equals U, which is a huge thing, that a person living with HIV, the undetectable viral load, cannot transmit the virus sexually. Zero. And so how do we share that information, and how do we push back on the stigma that Dr. Collins mentioned, that is so pervasive for people and communities impacted by HIV. So it has been a pleasure for me to share this information. And with that, I will stop talking and toss it back over to Ms. Charlotte to see if we have any questions.
Yes, thank you, Timothy, for that very informative, if not sobering, presentation. But sometimes you've just got to get the information out there, because if
Yep.
we don't know what's happening, we can't be part of the solution. So I
Yep.
do have a couple of questions for you, and the first question is right along those lines. In light of these draconian decisions, what can we, as participants on this call and just members of predominantly minority communities, and even those of us who live in majority communities, what can we do to combat the budget cuts that will negatively impact the HIV communities, therefore negatively impacting all of us?
Yeah, a couple of things. One, part of what I've seen since January, and it's really kind of the Trump world's kind of MO, is they love misinformation. They love disseminating just terrible information, just information is just flat out wrong. And so the one thing that I say, that I tell groups every time I do this, and I probably talk to groups probably 5 or 6 times a week at least. Push back on that. Make sure you know your stuff. And if that means we have to provide you, I am willing, me and my team, providing y'all some information to go out in the community to be able to share actual information, we will do that. So that's one. Make sure you're sharing accurate information to dispel this barrage of crap coming out of the White House. 2, make sure that you are keeping in contact with your elected officials, right? And holding them to an account. And not just on HIV issues, but everything. And not just federally, but I mean your alder, your county commissioner, anybody that represents you, holding them to account. Because that's what's going to matter, because so many of these things that they're doing in DC are going to have ramifications here in Illinois.
Yes.
And so make sure we hold them to an account. And then the final thing is, find you 1 or 2 organizations, especially if you're interested in HIV. And I can put some information in the chat that we can share with you all too. Make sure you find an organization you trust that does policy and advocacy work, so you will know when it's time to sound the alarm, you can do it really, really quickly. I am going to plug AIDS Foundation Chicago. And so I will put our information in the chat in just a moment once I find it. And it is quick for you to sign up. You can do it over the phone. You can go to our action center. And whether or not you choose AFC or whether that's ACLU of Illinois, whether that's, any other groups, maybe you all have one, make sure that you're constantly doing the work of taking action.
Okay, thank you. Got a couple other questions for you. What protections exist to ensure safety and transparency for trial participants?
Hold on just a second. Give me just a moment. For trial, I would imagine we're talking about clinical trials, right?
Clinical trials, yes.
I'm trying to figure out how I need to answer this, whether I need to give you Timothy Jackson, AFC Senior Director of Policy and Advocacy, or Tim Jackson, Rethink. I will give you the polished answer. One of the things that I tell people when we do clinical trials is to make sure that it is from a place that you trust, that you have kind of done your due diligence around. Like here in Chicago, obviously, like Northwestern does a lot of clinical trials. University of Chicago does a lot of clinical trials. UIC does a lot of clinical trials. Obviously, if you trust those organizations, that's something that you can rely on and protects you and make sure that they're doing work above board and all of that. However, so that's on one side. If in your gut it's telling you not to do it, don't do it. I'm gonna be honest. I can only be honest to you. If you don't, I know the history of our people and understanding the hesitation with doing that. But and so I generally tell people follow your gut because it's usually gonna lead you in the right place anyway.
That's great advice. And I've got another question for you here. If you could leave one message for Black communities about HIV awareness or prevention, what would that be?
Oh, wow. One of my favorite quotes is from Audre Lorde. And it is without community, there is no liberation. And that's the way I feel with whenever I have an opportunity to talk to Black people about HIV, is understanding that we can't depend on the CDC, the federal government, the state government. We can't depend on any of them to do this for us. And so it's important that we learn as much as we can about what HIV is and what it isn't. I make sure that I say that too, that what it isn't, and making sure that we learn as much as we can about it and we protect ourselves, right? One of the things that makes me so angry is the way we talk about PrEP. And I'm so glad Dr. Collins did not do that. Dr. Collins just basically laid it out. If you're having sex, you need to take PrEP. That's as simple as it is. It doesn't, and I wish we were that open with it because I think it would save so many people. Because when we initially came out with PrEP in 2012, so much of the messaging around it was if you were at risk for HIV and if you were no, because what that did was that created like these lanes that well I'm not at risk for HIV, so I don't need to take it. And what we've seen now are these huge disparities increase because we did it. We said initially when PrEP came out that it was for gay and bisexual men. Well, if that's what you tell people and you tell community, right? You can't be surprised when women represent less than 10% of PrEP users. I mean, again, this is simple. So, making sure that we get and learn everything that we can about HIV and what it is and what it isn't.
Great. Thank you so much. Sabrina, do we have any other questions that came across?
No, I think you covered all of them.
Okay, great. Well, Timothy, I want to thank you so much for taking time out of your incredibly busy schedule to spend some time with us and give us some straight talk on the challenges that are facing our communities in a disproportionate manner. And we really are appreciative of all the work that AIDS Foundation of Chicago is doing. And my committee is going to make a donation to AIDS Foundation of Chicago on your behalf.
Thank you.
And as a token of our appreciation for you spending some time with us this evening. So thank you so much.
Thank you so much. It's been an absolute pleasure. I am putting my information in the chat.
Great.
I would love to come back anytime. Y'all
Yep.
just let me.
Come out stronger when we're proof through the fire. So thank you again. Appreciate your support. Good night, everyone.
Good night. Good night.